Hey everyone, how's it going? It's been a while since I've made content for the OT community, so I wanted to get back into it. It's really what my passion is and where I work, and it's a really great community. So today I want to talk about, I guess, a controversial topic. Someone reached out to me on Instagram, and the issue that they're having in the workplace, I believe it's acute care, is co-treating. And what this OT feels like is that they're being pressured or guilt tripped into co-treating more than they think that they should. And this is not to throw any profession or anybody under the bus. I'm keeping names anonymous. And I believe it's the PTs who are often asking the OTs to co-treat. It can go both ways, right? An OT can be over-reliant on PT for helping them to mobilize because, PT traditionally what they do, mobilizing, right? And this person even felt guilty because they didn't feel like they wanted to do it, right? They helped a patient, I believe, transfer a patient, and they were able to do it. And then the PT thinks that they're like a max assist, so they need the OT to come in and do the co-treat. Otherwise, they're not going to do anything at all. So what are your thoughts on this? I want to know what your culture is. I think I already just asked this about co-treating. And every culture is different. Every organization is different. There may even be like policy, right? So I guess I'll offer some of my insights for what it's worth, right? Just one of my own perspectives. And some of you probably are going to agree with some of these points, some may not. Basically, I don't think there's a black and white answer when it comes to co-treating or not. It runs on a spectrum. And I think the number one thing that I would personally prioritize is safety, right? The safety of the patient, where you don't want them to fall, get injured, right? And you also want to think about it from the perspective. And I think this is one thing that may be helpful to help you decide whether to co-treat or not, is the perspective of the patient too. And if they're having someone like come in and step in, like two people co-treating, will it build their confidence? Probably. Or it could also work the other way around too. It could feel like they're like very dependent, not very capable, and they need a lot of help, right? It's like, oh, you can't even, help get me up. You need like so many people, like a team of people, right? So I think it can go both ways, right? But I'm going to speak strictly from kind of what I see in the contrast between acute care and ARU, acute rehab unit. And I would say like 99% of the time, I'm by myself. I don't co-treat. I know it's not as acute, right? So patients are more stable. They're able to tolerate that 3 hours of therapy, combined PT, SLP, OT, right? One of the times that I co-treat in ARU is really for safety. Like it'd be like spinal cord injury, like mainly like where they have they're like a quad, right? Even like that is when we need like co-treat, and it's mainly even just to like mobilize them from a transfer from like bed to wheelchair, and like that's it. And like because after you get them there, like the goals are different from this kind of patient population than say in neuro, like stroke or TBI, right? Whereas like in ARU with like stroke, TBI, neuro conditions, those who have a lot of comorbid deficits, not only physical but cognitive, right, psychosocial, I can still get them up into bed, out of bed, into the chair, in the showers, all by myself, right? And I don't think it has to do with anything to do with my physical capability. My colleagues who are OTs and ARU can just do the same without any help, Okay, now acute care, right? I think it's definitely more utilized because of what the patient may need, right? They are going to be more acute in acute care. I can't speak for ICU because I haven't worked there personally, but a lot of times, because I float to acute care, like it's the PTs who ask me. I'm like, oh, okay, yeah, maybe a co-treat would be appropriate, especially because they often like evaluate them first before OT does, if that's the case, or if they work with them before, because I float, so I'm not as familiar with patients. Usually they're new to me every time, and I do a chart review. I fall somewhere in the middle. Like, again, it goes back to safety, but I think the number one pro to co-treating is, of course, safety. You have less risk of the patient getting injured, falls, injuries to staff, so on, so on. And maybe the close second to a benefit of co-treating is efficiency, right? You can ask like a lot of questions all in like one session. You can like tag team off each other. You don't have to be redundant really, right? Because if it's like OT sees the patient after PT, they're often going to ask some of the same questions, right? It may seem redundant, right? And you don't know because you don't know what the PT asked, right? Even if you're like really familiar with the PT, you don't know what they like literally asked, So to the patient, from a patient client perspective, it may seem like they may not feel like they're listened to, I guess. It's like, hey, didn't I just answer that question with the other therapist? I think the other benefit really is just the collaboration piece. You can really like work well together and kind of check a lot of boxes, like not, was it two birds with one stone kind of thing. But really, I think besides that, that is really where the pros end when it comes to co-treating, right? Because you often have to share the time too and billing and split it. You think about it from the patient perspective, now it's time to really to advocate for OT and why I think there's a lot of cons to co-treating. One, patients don't know what OTs do in the first place, right? So they see two therapists, primarily a physical therapy working with them to mobilize them. They're going to think there's like two physical therapists more than likely working with them, right? So it doesn't really advocate for our profession. And two, it may not even look good because if nursing was able to mobilize them like by themselves, and then you do a co-treat after, it like confuses the patient, right? Everything in terms of the team should be cohesive and collaborative and really like smooth and not contradictory. So we shouldn't be having like one staff, whether it be a nurse or a care partner, transfer them by themselves. And then you have like two therapists coming in, transferring them like at another time in the future where they should be further along in the recovery. That doesn't really make much sense to me either. And then we talk about goals, right? Co-treating isn't good because PT has their own goals and OT has their own goals, right? Even though we both have our own goals from our own professional perspective, you can't hone in on them in a session that's co-treated because there has to be give and take, right? PT has to give a little bit and OT has to give a little bit. So in that way, it's less efficient in terms of knocking out the things, for example, that you want to do as an OT, whether it be ADLs, IADLs, social support and family education, leisure, sleep and rest, health management, right? There's so much that can go into it. So it isn't efficient in that way when it comes to that. In fact, I think if we were to co-treat, this Instagram user made a good point that nurses have a lot of goals that are actually quite aligned or even more aligned, you could argue, with OT than PT does with OT. You think about like ADLs, there's toileting, right? Dealing with incontinence and dressing, getting them dressed and undressed, skin checks, self-feeding, all ADLs, all things that nursing does, right? Bowel and bladder, in and out, eyes and nose, right? Their vitals, their medication management, health management, now that's an occupation. That's also nursing. So if anything, nursing should collaborate and co-treat with OT just as much as with PT, right? And just as much as with speech, and not even get into like SLPs, right? There's a lot of goals that we can collaborate with them as well, or even mental health. Often the co-treats that you do see are PT, OT, but really, I want you guys to think about it from the patient perspective. And is it doing them in terms of any good of really knowing what OT is about, what the goals are for our OT about, and really, is it pushing for our profession and setting us apart and defining what OT is and how we're different than PT? Because that's an ongoing problem. PT has no problem defining what they do. But OTs, I feel like when they do co-treat, they kind of like are masked under, they're hidden under, they aren't really standing out in what we're doing. And that may not do so much for advocating for our profession, defining our roles as CODAs and OTs when it comes to whichever setting, I would argue. And last, I guess it depends on, well, what should you do? One, I should think it depends on the culture where you work and what the policies are. Maybe even talk to your manager, right? Because sometimes you may feel like, probably management often feels like co-treating is less better, I would probably think, than less is better in terms of co-treating than more. Yeah, I think that's definitely the case. Like in ARU, it's probably preferred that we, especially to meet the hours, right? It makes more sense to have less co-treating sessions to meet the 3-hour requirement. In acute care, it's not so much the case, in insurance and like that kind of thing. But I just think in terms of one thing, I just remembered therapy time. The patient's going to see and get less therapy when they're co-treated versus when it's not bundled together and it's separate, right? They're going to see either OT first and then PT next, or vice versa. They're going to see PT first and then OT after. So in terms of the patient getting more therapy, not co-treating would be better because they're getting more practice, more opportunities. Even if they're doing like very, very similar things, they're doing more of it, right? This is not, of course, like you're forcing patients out of bed and like dragging them out of bed. They're appropriate for it, that they're actually getting more therapy and more practice. And we know like for conditions like stroke with neuro, right? More practice is better. Repetition, repetition, repetition. More mobilization is better, right? More out of bed, less bed rest. All those outcomes are going to be better with more therapy. So from that standpoint, almost forgot to mention that. It's more therapy. I think co-treating should be reserved for absolute necessary cases in terms of safety in being able to get the patient out of bed. But you also think about it again from the patient's perspective. What does it do for their confidence? Does it build their confidence or does it lower it? What does it do for their awareness of what the OTs do in their profession? And in terms of like co-treating, they shouldn't be thinking that like OT is always tagged along with PT, right? There should be separate goals because that provides us a space and an opportunity for OT to set and help the patient meet these separate goals. Now, again, like in settings like, I don't know, like ICU, I haven't worked there, but I will see this as definitely more like of the case because the co-treating, because, patients are confused, physically less capable, more deconditioned, more acute, more lines to manage, so on, so on. So I definitely see more of the, appropriateness. And then in terms of SNF, I personally haven't worked in the SNF setting, so I want you guys to kind of chime in the comments. Let me know, what's it like in the SNF? Do you guys co-treat a lot? Now, after like the changes in like Medicare,